Hi, good morning, good afternoon to everyone who's joining us. Thank you for joining the June All-America City Promising Practices webinar featuring health equity strategies. My name is Sarah Lipscomb, and I'm the director of the All-America City Award program here at the National Civic League. And for those of you who don't know, the National Civic League is a 123-year-old nonprofit, and we aim to create inclusive, thriving communities by inspiring, supporting, and recognizing equitable approaches to community decision-making. And this morning, I'm joined by my colleagues at the National Civic League, Erin Levy and Melanie Foster. And we are really glad to welcome you guys to hear our speakers this morning. And they are from a project that we do with the Robert Wood Johnson Foundation. And we give an award each year that recognizes and honors individuals that have successfully implemented a systems change approach within the past 2 years to improve health outcomes for those most impacted by health disparities. And it often takes a community or multiple groups to bring about systems change. And this award really celebrates those individuals who are leading the change and helping to create a culture of health in their communities. And this is the second year that we have been able to give out this award with the Robert Wood Johnson Foundation. So we are very happy to have speakers from our 2016 award winners and our 2017 award winners. And before we jump into their presentations, just want to let you all know we are recording this webinar. It will be available to you directly after, so you are welcome to share it with your networks. And it will also have contact information for our speakers today. We really want to promote the work that they're doing in their communities and hope that it helps inspire you all and give you some help and tips in how you can do this work in your communities as well. And so with that, I want to go ahead and get started. And we will turn it over to Dr. Terry Richardson and Ms. Thelma Craig with the Colorado Black Health Collaborative. Terry and Thelma?
Hi. Hi, good morning. This is Thelma Craig, and I'm the chairman of the board of directors with the Colorado Black Health Collaborative and the program manager.
Hi, and I'm Terry Richardson. I'm the vice chair of the Colorado Black Health Collaborative and an internal medicine physician.
So good morning, everyone. We're really excited to be able to just talk about some of the work that we're doing. So next slide, please. The Colorado Black Health Collaborative, our mission is to achieve health equity in Colorado's Black community. We're a 501c3 organization. We're committed to improving the health and wellness of the community by teaming arrangements and collaborations and partnerships. We were born, and we like to say born, in 2008 at our very first family reunion where we were charged with, from the health department, the Department of Health, to bring the community together, to mobilize the community and inform them about health disparities. And so that was the beginning. And so the community said, please come back, please help us address some of these health disparities and talk about health equity. And so we did. So our projects go from cradle to grave. We work with from new births, prenatal, all the way to end of life issues in the Black community. Our strength is our collaborative networks in the Black community. We are trusted, we valued. We feel like we have our finger on the pulse, including some unspoken truths. We have a diversity of Black culture among our members, and our members work in various areas of health. So we feel like we have a diverse team when we're addressing these issues. Next slide. We call them the 3 C's, but it's Colorado Black Health Collaborative, CBHC in a nutshell. We're collaborative. We make sure that everything is culturally proficient. We involve the community in engagement. We have community education, community empowerment, and covering all lifestyle cycles, like I mentioned before, from prenatal to senior in all areas of health, including the social determinants of health. Next slide, please. Our background REACH project. So in 2014, we were awarded a CDC, Center for Disease Control, REACH cooperative agreement. It was a 3-year agreement that started, like I said, in 2014, September. And our primary focus was to increase opportunities for chronic disease prevention, risk reduction, and management through clinical and community linkages. There were two key components of that project, and it still is. We're still engaged in that project, was to increase the number of clinics providing culturally chronic disease management and increase the number of clinics with enhanced referrals to the community-based disease management services. What that means is we went into two large health systems into the community, and we engaged them, their teams, to really help make the referrals to the community, to the black population around their cardiovascular health disease management system. And so we feel that it's been a really great opportunity to work with these systems. And so the really important number of reasons that we feel that it's important is because it represents a policy, systems, and environmental change. And I know that's a mouthful, but what it, in a nutshell, is really saying that we want the clinics to really reach out to the community resources to really support them in taking care of their patients. And also it strengthens and builds relationships between the clinical and the community providers, therefore building trust in the community. And if your clients are, the people are coming into the clinic and they know that the clinical system is aware of some of the resources and health services in the community, then the clients will really be engaged and really feel appreciated that the clinics are really keeping their issues and their care in mind. It also creates equity in the healthcare access. It also improves knowledge about the community resources for providers in the community. And what we found that the clinics are really, they were not aware initially of some of the community resources that were available in the community. And so that's really been an amazing part of this this project, is that it allows the clinics to get to know what, and the clinical providers, the healthcare providers, to know what was available in the community for their clients. Like, are there Zumba classes that they can refer their clients to in the churches? Where are the fitness classes, other fitness classes where they can refer their clients? Where are the cooking classes and nutrition classes that are embedded in the community where they can really directly refer their clients to those services? So that's really, it really has had an impact on the community and building those relationships with the clinics and with the community resources. So we really appreciate that. Next slide. So the clinical partner support from CBHC. What we developed a searchable database with culturally responsive community resources, so that the clinics can really refer to those resources. And these resources have been vetted. They're partners with CBHC, and we know their value. We've created a provider electronic handbook and a monthly provider newsletter to inform the clinics about what is going on in the community, what is CBHC doing to enhance the services out in the community. We personalize ongoing monitoring and support. We provided this support to the clinics so that, that if they're having challenges making those referrals to the community, we're there. We're there on the spot. We're there to be truly helpful. We created a F.L.O.W line. We created a 1-800 number, F.L.O.W, a telephonic support, so that if the clinics have questions or if the community has questions about the services, the community services that are available to them in the community. We also facilitate capacity-building workshops, train-the-trainer, and meetings so that we can bring these resources together with the clinics providers and really learn about what everybody is doing so we can build those and strengthen those relationships. We have a clinic and community provider engagement. We really, at some of our events, bring the providers to the events and meet the community providers and meet the community, the members of the community at large. And so we bring them together so that everybody knows what everybody's doing, and so we really try to make it a real seamless relationship in this process. Next slide, please. The Reach Community Health Impact. We really feel like this project has impacted the community, and it will continue to because of that systems change. One, it has the potential to increase the use of community-based resources related to better control of chronic disease. The project is devoted to health in the Black community and promoting healthy lifestyles. We really feel like we have an impact in the community. We want people to come to Colorado and say, those Black people in Colorado, there's something about them. They're always talking about healthy eating and active living. And so we want to really promote a healthy lifestyle beyond the clinic walls, but out into the community. we want this to serve as a model for true collaboration between the community and clinical entities. Like I said, when you bring the clinic providers together and the community providers together, it really brings about an awareness for what everyone is doing, so that way we can provide better support to the clients and the patients that are engaged in the clinic setting. But ultimately, this can lead to reduced rates of death and disability due to diabetes, heart disease, and stroke, which you know have a higher incidence in the Black community. And so we really feel like this is having an impact, and it would have a greater impact to come. We really appreciated this opportunity to work with the clinics and the community providers. Next slide, please. So we had to form a campaign to really get the community engaged and the community involved with what we're doing. So we created a campaign, our communications team, called F.L.O.W. And F.L.O.W. is Form a Lifetime of Optimal Wellness. And we chose F.L.O.W., the acronym, because it was appealing, it's culturally appropriate, you know, the concept is versatile for use in many settings, and it's really just a really good niche for the community. They like saying go with the flow. They like saying let's get with the flow. So we really hashtag this flow and really use this a lot, and really it has caught on. So we use it for various campaigns that we're doing because we really want them to, everyone in the community, to form a lifetime of optimal wellness. Next slide, please. So clinical linkage to community resources, that's the flow. That's who we are. That's what we're doing. So here's really kind of a campaign picture of form a lifetime of optimal wellness while the clinics are linking to the community resources. Next slide, please. Okay, so the enhanced clinical referral process. This really is the meat of the project. You know, we start with the patient, you know, and then it flows to, they find their flow. The patient visits the clinic, and the provider identifies the chronic disease, risk factors, and the need for community-based support. And so once they do that, then they refer them to those community resources. The provider refers the patient to that culturally responsive community resource to prevent and manage chronic disease. So really this is the outline to show how that flow works. So this is really the diagram for that, and so I hope that's understandable. So next slide, please. Next slide, okay. So the second component of this project was culturally appropriate assessments impacting the clinics. We really engaged the clinic by participating in a customized survey. You know, so our team analyzed the results of this survey, which we have the clinics to assess themselves, really to see just where they are in the spectrum of providing culturally competent care. And so as a result of that, we realized that the clinics realized it as well, that they had improved appointment systems, reducing the wait time for appointments. They increased their client satisfaction from 60 to 75%, and they increased the number of staff to help with the visits. And this really shows a commitment to the resources that don't necessarily pay for themselves. In this culturally competent process that we engage the clinics in, they realize that it's really a good idea to really go in and really look at yourself and evaluate how you're providing these services to the people. And so that really was a really exciting component of the project, really having the clinics to assess themselves, but really finding out where there's some improvements, where they can really improve on providing the care that they need for their Black patients. So we really were excited about that. And so that is really kind of a nutshell of the Linkage to Care project, and so we're really excited about that. And from here, I'm going to give it to Dr. Richardson for the next slides. Thank you.
Thank you, Thelma. And so I'm going to talk about our barbershop salon health outreach program. And it is really about health outreach. I'm going to start out with, you see these numbers here, 190 over 130 and 180 over 24. These are really extremely high numbers, and they're actually real numbers. This was a gentleman in one of our shops. He actually was a shop owner. Every time we went into the shop, he at first didn't want to get his blood pressure checked, but he'd encourage his clients to get their blood pressure checked. And finally, we got him to come over, and we saw these numbers, and we said, oh, wow, this is terrible. You've got to do something. And he said, I'm kind of busy. And then we overheard him once talking about his father who had a stroke. And he said, he's so hard-headed. And we're like, hard-headed? Do you know that these numbers will lead to a stroke? So we eventually were able to get him connected. He did not have health insurance, but we connected him with one of the safety net systems here in Colorado, and now his blood pressure is doing much better. But this is of why we're involved with the Barbershop Salon program. Next slide, please. So we know that really place matters. When you go into these shops, they're really great cultural institutions in the black community. Some people call the barbershop the black man's country club. But it's a meeting place where people really feel they can trust that environment. And the barbershops and salons have been shown to be effective locations for community-based health interventions and health outreach, just really vehicles for health promotion. You don't have to bring the people there. They actually come there. And if you focus health outreach efforts in places that are kind of out of the traditional clinical setting, we know that there's great promise there in helping to reduce disparities. Next slide. So we call it screening with a purpose. We know we need to eliminate cardiovascular disease and stroke disparities, and we know that men are much less likely than women to go to the clinic. There was a study by a guy named Victor who's gotten an $8 million grant at one point, but he estimated that if you extend health care interventions to all of the approximately 18,000 black barbershops in the U.S., you could result in 800 fewer heart attacks, 550 fewer strokes, and 900 fewer deaths among African-American men in the first year. Next slide. So why do we do high blood pressure screening primarily? We actually do high blood pressure and diabetes screening, but the reason we do high blood pressure screening is that because, first of all, blood pressure screening is very easy. You don't have to have an MD or PhD to do blood pressure screening. And it doesn't require a lot of time. If you've been in a barbershop or salon, sometimes the salon, the women are in there for hours, but the men are in and out. They may be in there for 10 minutes. They may be in there for 20 minutes. So you have to be fast. And for those of you who are more technical, the U.S. Preventive Task Force gives this a grade A rating. They give hypertension a grade A rating, which means it should be offered as a priority. And we define high blood pressure as a blood pressure of greater than 140 over 90. That's the standard for that. So next slide. So challenges to high blood pressure control. We always try to look at the evidence base for some of the things that we're doing. And we came across this one article by Dr. David Satcher, who was a former Surgeon General, and he mentioned there are 4 components to the challenge of high blood pressure control. One is access to care, physician management, patient adherence, and then hypertension severity or the physiologic differences in response to treatment. Now, as a community entity, there aren't a lot that we can do about the last bullet point, but we can do something about the access to care when we're meeting people at the shop. We can do something about the physician management because we can encourage the patient to be empowered to talk to their doctors about diet and lifestyle. So about our CBHC Barbershop Salon program, it started in 2012. We currently have 12 shops, and many of the shop owners are very engaged. They didn't start out that way. At first, they were a little suspicious. What do you people want from us? But over time, we have some real champions. They've said, sit down there, man, and get your blood pressure checked. One woman says every time her clients come in, these people saved my life because she was going to the doctor all the time. We asked her to sit down. She said, oh, my blood pressure's fine. We checked it. It was high. She said, your machines are wrong. But then we said, go to the doctor. When she went to the doctor, her blood pressure was indeed high. She had developed a kidney disease. So she tells all of her clients, you sit down. These people save your lives. And we primarily do the high blood pressure and diabetes screening and education, as I mentioned, because those are low budget and they're easy to do. To date, we've screened 6,170 clients for high blood pressure. We've had over 5,000 volunteer hours, and here in Colorado, you can multiply that by 25, and that's a lot of resource. Move on to the next slide. So there's many other possibilities at the shop. We talk about high blood pressure and diabetes screening and education. We talk about lifestyle. But we've reviewed the literature. You can do nutrition screening. Some people do HIV testing, colorectal screening education, breast cancer screening education. You can also do blood pressure, glucose, HIV testing. Some places have even done prostate. And if you think of other things, lipid screening, there's lots of possibilities. Some clinical sites now are thinking about this as an authorized capture point, meaning that their clinic patients can come to the barbershop and salon and get their blood pressure checked, and that can count as a blood pressure reading in the clinical setting. Importantly, also, we have developed a toolkit. People are asking us, how have you done it? We didn't invent this program. It kind of fell into our laps. It was low-hanging fruit. But we decided we should share some of the things we learned with the rest of the nation. And so we have a toolkit, everything you want to know about starting a barbershop salon outreach program. And it's available on our website at www.coloradoblackhealth.org. That's our website. Next slide, please. So I want to share with you this last quote, and this came early in this project. It was from one of the former clinic medical directors of the clinic that we're working with, the Safety Net. He said, "This is great stuff. We are happy to be part of this program as it so exemplifies the value of culturally appropriate outreach, access, and early intervention for prevention of things that matter in healthcare. I just saw a new patient this week that you guys connected to care with uncontrolled hypertension and diabetes. He was so appreciative of the ability to gain access to care." Next slide. And that's what this is really all about, connecting people to care, doing it in a cultural way, meeting people where they're at. And we're going to have questions after the second presentation, so thank you for allowing us to share our passion about the work that we're doing here to improve the lives of the Black folks here in Colorado.
And these are just only 2 programs that we do. We do a couple of programs, but we really are really excited about the work that we do. So thank you.
Great. Thank you so much, Terry and Thelma. And as they said, we're going to hold questions until the second presentation as well. So with that, I'd like to turn it over to our 2017 Robert Wood Johnson Foundation Award winners. And we have Elizabeth Bustos and Reverend Gerald Brown with the Southeastern San Diego Cardiac Disparities Project.
Hello, everybody, and thank you.
Hello, and thank you. And I know that we're going to hold questions to the end, but I just want to applaud the work that's being done in Colorado. You folks are working after God's own heart, and so I guess we're not supposed to say that. We're supposed to get directly to the PowerPoint, but I just wanted to say, wow, you guys are doing great work. And it just really excited me that I couldn't yell and scream while you were doing it, but we are yelling and screaming in our spirit now.
We were cheering you on while we were on mute.
Yes.
And celebrate you. And this is all coming together, Dr. Richardson and Ms. Craig, because in listening to your presentation, what is clearly evident and obvious is that we are sisters. We are sister projects. And you are excellent models, role models for us and inspiration. So Reverend Brown, you with that said, did you want to just get started?
Let's go.
What we share. We are the REACH, Southeastern San Diego Cardiac Disparities Project, and like Colorado Black Health Collaborative, our work is funded by the CDC, Centers for Disease Control and Prevention, and the project is improving the heart health of African Americans in our community by changing 2 fundamental systems that can influence their health, faith organizations and healthcare provider systems. But what we know and what we learned and how we got started is that we knew that at the heart of this project is trust and the power that healing can build. Next slide, please. Oh, can I just stop? We can just go back to the previous slide, please. Thank you very much. And I echo the sentiment about the phrasing of community clinical linkages. That is a mouthful, especially for somebody like me, and English is my second language. I think that will become evident as we move forward, but it just doesn't roll off the tongue. And as we were setting the table for how we were going to make friends and move in the community, we came up with this work had to be at the crossroads of community medicine and justice. And I just wanted to, so that's our CCL definition.
Next slide. So we had a huge, goal, a mission. Our mission is to eliminate heart attacks and strokes in San Diego, to make San Diego the first heart attack and stroke-free zone in our country. We started this with when Ms. Bustos brought this into me as a possible project. I looked at her and called her crazy, but we began to take a look at the numbers, and as you'll see later on in our slide presentation, that Southeastern San Diego, which is where the largest percentage of African American population is in San Diego, we're dying. And so we have to do something a little bit different. And so we brought together these nonprofit organizations, including our faith-based organizations and our churches, to work towards eradicating, eliminating, getting rid of completely, and making this a heart-free stroke zone. I am from an organization called the United African American Ministerial Action Council. We've been here in Southeastern San Diego for the last 22 years working in the community. We are striving after Dr. King's vision to build the beloved community, a community of education, a community of justice, a community of economic development, and a community that is healthy. And we're doing this through, and this is why I got excited listening to your presentation in Colorado, we're doing this through commitment, through communication, collaboration, consideration, cooperation, compassion, caring, and the love of Jesus Christ. Unless we do this, and I saw you had 6 C's, and so I have about 7 or 8 C's that we can go on, because I'm going to adopt some of yours, what you're doing there. But we want to bring people together, and we want to empower folks in our community for them not to wait on anyone else to come in, that we have to be the captains of our own ships and the masters of our own destiny. And so this is what UAMIC has been doing for the last 21 years in this community. Next slide, please.
So this is just a map that shows our community, Southeastern San Diego. And this is a community that is the home, as Reverend Brown mentioned earlier, is the home of a large African-American population that is really disproportionately experiencing the effects of chronic disease and associated factors, particularly cardiovascular disease. Poverty, low levels of education contribute to the health disparities in that community. You know, what is really at work, though, in Southeastern San Diego is just barriers. We struggle against, social barriers such as poverty, poor performing schools, lack of economic opportunities, and an inequitable criminal justice system. So those arching realities that I just mentioned was really the challenge, and was really where this project was introduced and absolutely needed to succeed. Next slide, please. And just really quick demographic slide about Southeastern San Diego. We're actually very multicultural, a very multicultural community. And Reverend Brown?
We, as you see, that African Americans, we set as approximately 21% of the population, 51% being Hispanic. The 16% we see Asian, and we have a large African population of Somalians and Ethiopians that are here in Southeastern San Diego.
Next slide, please. So this is our community's reality. Every year in San Diego, 7,555 heart attacks, 6,700 strokes. But in Southeastern San Diego, there's 791 heart attacks and strokes. And this is what we absolutely know, that working together to raise awareness to promote heart health, we can eliminate 10,000 heart attacks and strokes every year in San Diego County, 791 heart attacks and strokes in 10 heart attacks and strokes every week in southeastern San Diego. Next slide, please. So this is our goal. We call it our covenant. This is literally what we submitted to the CDC in our REACH grant application. To improve cardiovascular health of African American adults in southeastern San Diego through increased healthy behaviors and the management of risk factors to end heart attacks and strokes in the historically under-resourced southeastern region of the city of San Diego. So that's, what we said we would do is that we would recruit 15 faith-based organizations and have them develop heart health action plans to address those PSEs, those policy systems environmental changes that were so wonderfully defined earlier on by our Colorado friends. PSEs that address health equity in the African American population. On the clinical side, we would recruit 45 clinical champions to implement practices that address cardiovascular disparities in their clinical settings. And then ultimately, we would reach up to 6,400 African American adults in our community. Next slide, please. Okay, so then came the challenge, the task, the lots of thinking around how we would introduce what we knew could be and would be life-saving work into a community that it was just so incredibly fragmented and in pain. So we started right out of the gate with some non-negotiables. And I'm going to turn this over to Reverend Brown. So,
and this date should hold for those of us that are African Americans and even not on this call, June 19th, which is otherwise referred to as Juneteenth. We came before the community, and here in San Diego, both on television and then throughout, and we said to the county of San Diego, in the words of Dr. King, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And we have to do something about the fact of folks dying in our community. It has become too commonplace that we know someone that has heart disease or has hypertension, and we know someone that ends up in basically not living towards their full purpose that God has called for their lives. And so on Juneteenth, we went forward. The next slide, please. On Juneteenth, we went forth, and we utilized the scripture to say, create in me a clean heart, renew in me the right spirit. We believe that every person born has a God-given gift and talent and purpose. And while we in the church say that, when a person passes on, well, they've gone on to be with the Lord, they're in a better place and everything else. Well, the question is, was it their time to go? And we've been hastily going along trying to justify people in our community dying early, but we hold the power in our hands, and God has given us the talent around us to do something different. So we decided we will no longer sit idly by, and we're going to be there for one another. Catch that, be there, San Diego, be there for every member of our community. And we're going to we're going to lift them to their greatness and for their purpose-driven life that God had intended.
Go ahead. And thank you, Reverend Brown. And June 19th, if I could just stay on that slide for a moment, please. The previous slide. Thank you. What I wanted to just mention, and it's very, very important in the consciousness and the life of this project, is when the work was launched. June 19th, 2015, 6, 7, 8 months after many hard-fought conversations with our community, who are now our community partners. And we did it June 19th for a reason. It's Juneteenth.
Right.
And when our community would, as Reverend Brown stated, would declare freedom from the bondage of cardiovascular disease. Much planning went into it. And for us, personally and professionally, then something happened 2 days before, on June 17th, 2015, that put, and I have to share this with you, put serious doubts in my heart as to whether or not the timing was right for this project. Questioned whether the time was now to introduce a celebration of life in our community, whether now was the time to hug and embrace one another and affirm each other's value. Because on June 17, 2015, was what happened at Emmanuel African Methodist Episcopal Church in Charleston. And the entire nation, indeed, we know the world paused to grieve. And so I recall that very same day literally running into Reverend Brown's office saying, and literally falling to our knees, is this the time? Can we continue? Well, we were in such pain.
So we decided that we would go ahead with the celebration of life as Pastor Pickney wanted us to do. We decided that in keeping with June 19th being the day that the slaves were notified 2 years after that they were free in Texas, we decided that we had to move forward with this project. And we brought the churches together to say that we would not be deterred by the madness that's going on in this country, that we had to stay focused. And so we used that to celebrate the lives of the individuals that had given their lives at a prayer meeting. We used that to bring together about 70 or so seniors at the George Stevens Senior Center to get their blood pressure monitored, as well as to get their diabetes read, their numbers read. And so if you could, next slide, please.
And this icon here will look very familiar as the hurdles in our community, and it's the icon that really talks about the social determinants of health. You know, everything that impacts your health, the neighborhood and your built environment, your access to health care and the quality of that health care, you know, social community context, education and economic stability. And so what you see next to it is what you see is that very same icon turned upside down and inside out. And so this is the community, this is the context into which we launched our work. Next slide, please. So early on, it was clear that we needed to understand what mattered and what were priorities, what were the conversations taking place in our community to help set the table. And what matters to us, and this is what we talk every day, we know that race, history, place, policy, and equity, we look at equity and we call that justice matters. This is, you know, what we know about race, that, you know, cardiovascular disparities vary according to race. Given the same risk levels, African Americans have greatest risk with Hispanics, then Asians, having the least 10-year cardiovascular risk. And forgive me, I'm going to take a sip of water. We know that historical contexts matter. Historical and cultural experiences in the U.S. can lead to higher levels of stress that result and contribute to higher cardiovascular risk. And then we also know that where you live, many times your zip code is a more accurate predictor of longevity than your genetics.
And we also know this, okay? Sometimes in taking a blood pressure and just looking at the average life of an African American, of a black person here, we talked a lot about the allostatic load of just simply being black in America. And so we had to deal with all those hard conversations. We talked about the issue of the trust that as it relates to medical professionals and clergy and everyone else. And so we decided that we would take this from two approaches. One, we would go with working directly with clergy, and the other would be working directly with the faith leaders. The church has always been, throughout this country, throughout this nation, the hub in the African American community. Folks were born in the church, raised in the church, and often died and was led down the aisle in the casket in the church. And the prayers were for their life that went on. And so the church serves as that hub. It's kind of like that other place from the barbershop that is, if you want to find out what's going on in the community, you go to the barbershop and the salons, and you also go to the church, you know. And so you had to find that place of trust. I was told that they trust that person that's working on their hair. They trust that person that's ministering them from Almighty God. So that's the approach that we took here.
And thank you, Reverend Brown. Next slide, please. So in the spirit of that hard-to-pronounce phrase, community clinical linkages, we immediately recruited what we lovingly call our champions in chief. And of course, you're hearing from Gerald W. Brown, our executive director of UAMIC, United African American Ministerial Action Council, as our faith champion. And then on the clinical side is our beloved Dr. Rodney Hood, who is president of Multicultural Medical Group, CEO of Multicultural Health Foundation, but more than anything else, in our community, in our region, for over 45 years, just really being and recognized the champion of health equity in our community.
Dr. Hood also served on the National Medical Association board as a past president. He also was an advisor to the former president of the United States as it relates to African American health in our nation.
So we have treasure in our community.
Yes.
Next slide, please. And so our influencers, Reverend Brown.
So as I mentioned a few minutes ago, the issue of health in the church has always been there, but the church, some having, ranging from 2,000 to 4,000 folks, and other congregations ranging down to 20, maybe 10 in some cases. It's been the issue of resources and what do we do. And so we started to bring pastors in to have the hard conversations to say, Pastor, we appreciate the sermons on Sunday, and hopefully they will take us all the way back through to the next Sunday. But people, as you know, are dying. You're doing funerals every week, and we're doing a lot of funerals and visiting hospitals that we should not, and it's time for us to step in the leadership role, and not that they weren't, but to really start to educate our people about life, about what we're eating. Anyone can tell you that oftentimes when you go to church and after church there's a banquet and a get-together, and there's fried chicken and there's hog maws, and I'm reflecting back to Louisiana now, and there's potato salad and all those things that taste good but may not necessarily be good for the community. And so as we begin to see these health disparities, whether it be cancer, whether it be heart disease, whether it be anything that pops up in the African American community across the country, we see this continual need for education. And so the church, who plays a critical role, had to connect the community members to work together to bring this blood pressure down and to eradicate these heart and strokes.
And thank you. So again, we couldn't think of a better leadership than the faith-based organizations. And then the next slide that follows are really our partners, whom we know are the heart, body, and soul of our community. And Reverend Brown, you want to talk a little bit about the diversity and who these congregations represent?
So these congregations here represent about 7,000 souls throughout the Southeastern community. And as I mentioned earlier, we have churches on here that have 2,000 or 3,000 members. Then we have churches on here that have 10 members. We have crossed denomination and also religious affiliation. As you see, we have a mosque on here, Muhammad Mosque number 8, because we're all suffering from the same thing. We have crossed denominational lines of Baptist, Methodist, Episcopalian, Protestant, Catholic. We've crossed those lines and brought those pastors to the table and said, you know, whatever your denominational disagreements are, you know, you can keep those, and that's adding stress. But what's really important is how do we change these numbers and eradicate heart disease? And so, again, we found them to be at the table, coming willingly to the table because they realize that some of them are suffering from heart disease. I have a pastor that has had open heart surgery. I have pastors with hypertension, prostate cancer, and other disparities. And so they saw the needs. I have pastors that are 80 years old. I have a pastor that has 5 stents in his heart. And so what Elizabeth and I have did is that we've gone out to each church. At one point we had 22 churches, but we've gone out to each church and met with each congregation. And as we began to tell our story and tell what God has delivered us through, we were amazed at the number of people that came out and began to share on what they had been through as it relates to either themselves or their family in dealing with heart disparity in their lives.
Next slide, please. So what the work looks like is that our 19 churches and a mosque each developed a heart health plan to raise awareness of risk factors and manage chronic diseases and obviously support the linkages to physicians. And what that really meant is the non-negotiables. Each heart health plan had to have a blood pressure self-monitoring component. It had to have a physical activity non-negotiable component. It had to have nutrition. And also another non-negotiable was the commitment from the faith leaders that they would create and promote a safe space for these activities to come to life. And Reverend Brown, can you talk a little bit about the philosophy and the vision behind the Heart Health Plan and how it was important for each church to develop its own identity?
One of the things that we did in this project is that, you know, no one likes someone to come into their house and tell them what they're going to do in their house. And so it was us sitting back and saying, you know, what's the best approach here? We went into the pastors and asked the pastors, what's your vision for your congregation? What's your health vision for your congregation? What would you like to see happen in your congregation to promote health? And how do we help you to do that? We went as far as even, you know, assigning someone that if the pastor did not have time or he didn't have someone in his congregation to help him to draft up a heart health plan to have that person, have one of our staff persons go out, meet with that pastor, and help them to develop a plan. So far, we've done this for going on our 3rd year now. And again, this is their plan. It's not my plan. It's not, you know, Be There's plan. It's not the CDC's plan. It is their plan, their vision for their church and their church and their members' health. We also did something very, very unique in this situation because we bring the pastors to a monthly informational meeting where they share what they're doing in their churches. But one of the things they said very early on was that a lot of people come into our community. Elizabeth and I have been in this community just about all our lives. She's been here for 30 years working in the community, and I've been here since 1971. So that doesn't mean I'm going to tell you how old I am. But nonetheless, they recognize that people come into our community, they gather information about what's going on in the community, they take that information and they use that information somewhere else, never to hear from those folks again. And so we had to gain their trust and say that whatever data that we received, that data didn't belong to us, it belonged to them. They have access to everything that we do, to include the PowerPoint, to include anything that we send to the CDC, anything that we send anywhere. The pastors have the first go around to see the first draft, the final draft of what goes out of this area. Additionally, we took a homegrown person, a doctor, and designed a tracking system along with an app to give to the church members so that they can track their information anywhere. And so we've done that. We've also made ourselves available for contact. We don't have that 1-800 number yet, but I like that plan. I think we're going to do that. But we made ourselves available for 24 hours around the clock. If you need us, we're there. We have a technician that's on hand. We have, as I mentioned, we have several doctors that are available. And some great things have come out of this, including a mobile van. One of the systems here donated a mobile van for folks to come in and get their blood pressure checked, along with the Black Nurses Association that's now going out to churches, as well as it also encouraged others to come out. The Susan G. Coleman van now comes out and does mammograms. And so out of this is owned by the community.
Thank you very much. And if we can go on to the next slide, and this is really our attempt at a visual. These next couple of slides are what a Heart Health Action Plan looks like in operation. At the center of it, and here you have Reverend Dr. William A. Benson from Total Deliverance Worship Center. He's at the core of the work in that community, in that church, and this is what is happening in this church now. Sunday, blood pressure screening, coaching. He's got a member of San Diego Black Nurses Association there doing screenings, the aforementioned app and tracker to digitally monitor blood pressures and over time, nutrition and food and beverage policy. There's the communication policy where messaging from the pulpit is integrated into all the communications. And then, on the physical activity front, walking club and even yoga for members of the congregation. And the next slide is Pastor Clarice Christian from Emmanuel Chapel Christian Church. And you want to talk a little bit about Pastor Christian's church?
Pastor Christian's church, Emmanuel Chapel Church, is like a lot of African-American churches here in San Diego. And she has a wonderful church. She has, I think, about 65 members that go to that church that she reported to me. She has about 80-some on the road, but she said, I want to keep it truthful. I've got about 65 that actually come to church. Long story short is she is renting her space that she has, but nonetheless, what she does is there's about 4 churches in there. She utilizes the space on Saturday. They come together. They hold health fairs. They do community walks together. She is a retired Kaiser Permanente nurse as well as a pastor. So she understands the need for her parishioners to be healthy. And so, again, they are the ones that are leading the charge. If you go to the next slide, please. Here again, you see everyone has become a heart health champion. So we've made each one of the pastors a heart health champion. What you see on this slide is you see the interaction of some of the doctors. We've had doctors that are going out to the church. We have instituted a program where we are having doctors adopt the church, okay? We are working with also students from our local college here, to medical students. We want them to do the same thing, adopt the church and make themselves available, because we realize that folks may not have the funds to have access to regular care, but we want them to have care nonetheless. And then we want to demystify doctors. We want to build that trust that's there. We had a doctor go out to the church, Dr. Dutto. We were sitting there in St. Stephen's Church of God in Christ, which is a predominantly African-American church. Has been around for about 75 years here in the community. And Dr. Dutto was sitting there, and of course, those of you that know that Baptist and Pentecostal praise is a little bit different. He was sitting there, and he found himself worshiping. And then, of course, you look around, and you don't see anybody that looks like you. Then all of a sudden, a lady came up to him and said, "Hey, I used to work on the same floor that you have. oh, you have connections. And so one of the things that we've been talking about is how do we build trust between the African-American community and the physicians that are there so that we just don't become another number that's passing through.
Next slide, please. And so this is, I think, our second to the last slide. So what's really flourished in our community is our learning community, where practitioners, the clinicians, faith leaders, patients, really community stakeholders come together to develop, these best practices. What works best for you to reduce your risk, to understand your risk, and for goodness sake, to get you to your doctor's office and remove those barriers. Emphasize patient-centered care, family and community involvement is at the center, and of course promote cardiovascular health through prevention, detection, and the treatment of risk factors. And then just to the last slide, if I may. So why does this work? And Reverend Brown, why does this work?
The reason this works is because it's not an Elizabeth plan or Elizabeth Bustos plan or a Gerald Brown plan. This is a God's plan, and God is taking control, and we are blessed to have wonderful people that are working with us. We are blessed to be on this call to talk with people that are of like-mindedness and folks that no matter how many times you've been told no, that this couldn't happen, you continue to press forward.
Thank you very much. I think, it works because who the partners are. It works because there's this resilience in this community. Yes, for all the wounded hearts, and there are plenty of wounded hearts in our community, there's resilience, there is hope, and there's partnership. And in such a way where when we first got started, folks literally said, this will never get off the ground. This community is too wounded, you're too wounded, trust issues, and it literally was one conversation at a time.
Yes.
One conversation at a time. And then just next slide, and we will pause.
I think we're done. You have our contact information. Please feel free to call us at any time or to email us. I think we just put our emails there. Okay, email us at any time, and then of course you can have our numbers. That's no problem. We're still working through this, and I've seen some things on the other presentation that we're going to adopt here as well. Hoping this has been a blessing to you, and we will continue to do what God has directed us to do.
Thank you.
Great. Thank you guys so much for joining us on the call and volunteering your time to share your projects. We are almost to the end of our time, but I just wanted to touch on a major point from both programs and a value that we really have here at the National Civic League, and that's working from the starting point of community members and building trust. And I just want to commend both projects for really recognizing the historical racism and mistrust of institutions in the Black community and how you all have been able to really partner, use collaborations, and work together to really get some strong outcomes on moving the needle for your community members and their health. So I know that we are up on our time, but I just do want to open it for a moment if anyone has any pressing questions. And if not, feel free to email myself or our presenters later. You will get an email with the recording of the webinar as well as their contact information.
Is that a question or a departure?
If anyone has any questions that they want to throw out before we wrap up, feel free.
I do.
Yeah, go ahead.
For the folks there in Colorado, what was your biggest challenge as you access the folks in the barbershop? Because I'm asking this question because I brought this thought to our small staff last week, and here it is. You guys are doing a presentation on it now, and the first thing that they told me was, Reverend Brown, no. You're thinking, and they're not going to So what was your first challenge as you went forward?
Let me start it out with a question. Reverend Brown, do you get your hair cut at any barbershop?
Yes, I get my hair cut at the Brown Barbershop. No, I do go to a barbershop, okay, and yes, ma'am, I do.
Okay, so that's the first thing. We actually started out our program at a barbershop that one of our doctors went to from high school, so we already knew the people from forever. And so when, of course, with him being familiar to them for other reasons, because he'd been there so long, they were open to allow him to come in. And so we've just set up a point person that will go to shops. If someone gets their hair done somewhere or their relative goes to a shop, those are the shops that we try to approach first, and usually they're the ones that are going to be the most friendly, where someone is familiar with them. They say, yeah, I know Susie or whoever. They're more willing to open up their shop and try it out. And we try to be as least intrusive as possible. So we haven't really had any challenges. Over time, sometimes they start fatiguing, but now we have 12 shops. Before we started with like 2 or 3, and then we worked up to 12, and we've even dropped off some because they've gotten fatigued or their business died down. But I think the key is to start with one shop where somebody has a connection, and we know how the community is. Somebody has a connection somewhere, start at that shop, and then now we're having a new shop saying, hey, we want to join. And we're like, we can't add on anymore right now. But they heard through another person, hey, we want to be part of this program too. And we're like, we can't increase right now. But that would be my suggestion. Start with a familiar place where someone has connection.
Well, and I appreciate that. And that's how we started as well with the churches. And so I appreciate that, and I think one of the things that I'm going to do is, you're right, our relationship with the doctors, we're going to utilize them. And then I'm also going to utilize our network of African-American pastors, because we have some pastors here that are barbers. You know, matter of fact, we have a couple of them that are barbers already. And so, so we're going to utilize them as well, you know. And so I think it was good. I wanted to hear that, and I kind of knew that. But thank you for reconfirming that for us.
And I don't know out there, keep in mind that if you are interested in starting a program, we're happy to talk to you on the phone about some of the logistics. It is in the toolkit, but we certainly will be willing to talk to you and kind of walk you through how to get started. We say if you've got a dime and the time, you can make it happen.
Well, we're going to fly y'all to San Diego, okay? I'm not coming back to Colorado, but we're going to fly y'all to San Diego. But anyway.
And this is Elizabeth again. I'm not sure how much we have left, but I just wanted to comment on how important, and the point well made, how important it is to start conversation with somebody that you know.
Right.
And who can assist you in making those necessary connections, who literally can usher you through the door. And
yes, definitely. It's all about building those relationships.
Yes. And it was in the Be There San Diego case, it was, you know, me knowing Reverend Brown for so many years, and then Reverend Brown having such a wonderful, you know, relationship and trust and friendship, really, and brotherhood with so many of the pastors in the region. So those were all non-negotiables, and every moving part of this project is homegrown, and that's another, I guess, non-negotiable that really helped move this forward. And we too, and I'm delighted to hear that there are so many other, in your case, barbershops that are interested in joining and coming on board here as well. I mean, it took us a year really of conversations, hard conversations around race and trust and who are you, and you're the government, you know, with the faith-based organizations, that there was a moment when we said to ourselves, can this really happen? To now, you know, we're at 19. There's what we lovingly call a waiting list that whom we are speaking with, because there's, and I know you know this, there's nothing like a peer endorsement.
Exactly. Let me just throw this out here because I know time is stopping, but we actually have worked with a guy named Steve that works at one of the Kaisers there in San Diego, and he actually was running a barbershop program. I can't remember the shop. I'll see if I can find the information, because he's one of the first people that kind of got us interested in doing a toolkit, because he said, tell me everything you know about getting it started. I went online, but I really couldn't figure out how to do it. And so we worked with him, and he actually sent us pictures of an event. He did it several Saturdays. I don't know if he's still going. But his name was Steve. He works for Kaiser. Yeah.
Yes. Well, great. Thanks so much for sharing that resource. We're a little past time, so we gotta wrap up. But thank you guys again so much for presenting. We'll send out the information, and we really encourage you guys to keep connecting, to share that toolkit, and to share the recording with your networks. So thank you guys so much.
Thank you. Thank you, everybody.
Thank you.
Bye.
Bye-bye.